So next is early rectal cancer. A 84-year-old man was referred by gastroenterologist who investigated him for rectal bleeding. Colonoscopy revealed small, flat, 1.5 centimeter lesion in the rectum, 6 centimeters from the anal verge. The pit pattern raised suspicion of malignancy, which was confirmed on biopsy to be well-differentiated adenocarcinoma. How would you proceed in the management of a small, possibly early rectal cancer? So history, examination, CT thorax, pre-op local staging by doing endoscopic and ERAS, endorectal ultrasound scan, endorectal ultrasound scan, and MRI. So endorectal ultrasound scan is a method of choice for T1 tumors, most accurate at distinguishing T1 and T2, low accuracy in discriminating T1 in substages. MRI modality of choice for T2 or larger tumors, able to provide better information about mesorectal involvement, like CRM, able to demonstrate extramural vascular invasion, relationship to surrounding structures like sphincters, levator, prostate, and for anterior tumors, vital relationship to the peritoneal reflection. CT staging revealed no distant mets. MRI concurred in finding that the tumor is confined to the submucosa, hence T1. In addition, there was no involvement of the circumferential dissection margin or any other local structures. What are the surgical options and what would you confirm in your counseling? So ultrasound dissection oncologically the most definitive option. Disadvantages include perioperative risk of rectal dissection and functional problem related to the low rectal dissection, and full thick cell resection as local excision in the form of transanal minimal invasive surgery or transanal endoscopic microsurgery. That is T1 tumor we can consider local excision. What rectal tumors are suitable for consideration for local cancers? So well differentiated or moderately differentiated, no extramural vascular invasion, less than 4 centimeter, less than 30% of the circumference, and T1 stage and imaging. Some evidence to consider T2 tumors if combined with the radiotherapy. Given his age and that it is an early rectal cancer, the patient chooses to have a local excision. Histology reveals T1 SM2 adenocarcinoma. What prognostic features would you look for in the histology report in deciding whether to advise formal resection? So the rate of lymph node mets for T1 lesion can be prognosticated from the depth of invasion or SM staging. SM1 up to 3%, SM2 8%, 8 to 11%, SM3 12 to 25%. So poor prognostic factors include the degree of differentiation, presence of lymphocyte invasion, tumor budding, like presence of tiny clusters of undifferentiated cells found beyond the invasion margin, and resection margin. Depending on the histological prognostic factors, balance with patient's fitness for surgery, a decision can then be made about the appropriateness of an anterior section. Thank you.